In the best case scenario, the skin cancer is removed because it's found early, but in other cases, it can be advanced and it can be going to the lymph nodes or travel elsewhere in the bloodstream and become what we call metastatic or advanced cancer. Once you have metastatic melanoma, then we're facing a difficult conundrum, right? We're dealing with a cancer that is now spread and can be quite aggressive. So let's talk about melanoma. What is melanoma? Melanoma is a cancer that is actually quite common. One of the most common cancers in human beings because it happens in the largest organ in our body, which is the skin. The skin has, as you can imagine, different kinds of cells, and the one that gives the skin color is there are melanocytes. Those melanocytes are tiny cells that are interspersed within the skin stratus. Basically, as you have, like normal cells that are lining up and giving the protection in the skin, there's always these tiny cells that release a pigment called melanin, and that's where the name of melanocytes came from. Those melanocytes typically just, give you the nice tanning when you get exposed to the sun, and also protects us from this, UV rays that come from the atmosphere and from the sun. However, over time, there is a chance that those UV rays damage the DNA of those, cells. And when the DNA is damaged and is not repaired, as happens as we get older, then we start to see cancer. And in this case, melanoma is the cancer that comes from those melanocytes. In the best case scenario, the skin cancer is removed because it's found early, but in other cases, it can be advanced and it can be going to the lymph nodes or travel elsewhere in the bloodstream and become what we call metastatic or advanced cancer. Once you have metastatic melanoma, then we're facing a difficult conundrum, right? We're dealing with a cancer that is now spread and can be quite aggressive. But luckily, thanks to clinical trials and new innovations, including immunotherapy and targeted therapies, we are now finding more options for patients with melanoma. So one story that is easy to remember is, for example, President Jimmy Carter. He was diagnosed several years ago, metastatic melanoma to his brain. That was a disease that during my training years several decades ago was impossible to treat. We gave patients treatment with a drug called dacarbazine, and that was the only option that we had. And unfortunately, patients didn't last more than a few months. But now, thanks to the advent of these clinical trials and many patients who courageously joined those studies and help themselves and other patients, now we have different options for them. So let's talk about those options. The first one is targeted treatments. So targeted treatments are specific molecules, typically drugs taken by mouth, sometimes intravenously, that are targeting mutations or changes that happen in the DNA of the cancer itself and that the cancer is, quote unquote, addicted to. So the same way we're always used to go the same way to work and to drive the same way no matter how much traffic jam it is. The cancers like to thrive in the same way. They just like to grow to the same pathway over and over. So melanoma, particularly the one that happens on the skin, there's also other kinds of melanoma, such as the eye called uveal melanoma. Those melanomas of the skin typically have, in about half of them, a mutation in a gene called BRAF, B-R-A-F, specifically in an area of the gene called V600. And there's basically a single change in a nucleotide or a little piece of that readout of that DNA. There's a typo. That single typo change leads to the growth of the cancer and the appearance of metastases and whatnot. So when we use a molecule that is inhibiting the specific BRAF mutation with these drugs called targeted treatments or tyrosine kinase inhibitors, then we are stopping the cancer growth for a significant amount of time. Beyond that, we also found that patients who have this mutation and you target them with the BRAF inhibitor, they have an escape pathway. Basically, there's a pilot driving the car and there's a co-pilot. If we stop the pilot, the co-pilot can take over. So how about if we stop both of them? And that came to understand that the secondary mutation is in down the pathway of that specific gene called MEK or MEK. So we use a combination of BRAF and MEK inhibitors stopping the driver mutation and the escape pathway. And with that, we led to actually less side effects, better responses that are more long-lasting. So in many patients with melanoma, that's a very good option for targeted treatment. After that understanding, we also realized that these melanomas had a lot of lymphocytes or defense cells around them, but they were doing nothing. Basically, the police was in town, but the cancer wasn't being attacked by them. And that is because the melanoma cells, knowing that they're part of our bodies, they showed fake IDs telling the police not to attack them. Now with the advent of certain immunotherapies called immune checkpoint inhibitors, we can combine those drugs and give the immune system an awakening. Basically telling the police, wake up and find those cancer cells that are there that otherwise we're not even looking into, and now we're attacking them and killing them. So melanoma is one of those tumors that responds extremely well to immunotherapy. And we recommend that as a first-line option for many of our patients, as we can now understand that immune therapy typically does the best responses, and then we can use the targeted drugs in the future in the event of finding the mutation and the patient be eligible. So as you can see, clinical trials have really made a difference in the lives of patients with melanoma. There's still a lot of room to grow and opportunities for patients to optimize their care. So I always encourage patients to look for options, to look for clinical trials, and not just when you run out of options, but from the beginning. So you can plan ahead, and when the time is right, you can enroll into those studies once you're eligible and not when there's nothing else to do. So please check us online. You can check the Massive Bio app. You can look at all those options that you can discuss with your oncologist, and hopefully looking forward to your feedback and see how more we can use technology at scale to help patients find clinical trials. Thank you.